Well, I think we're going to get started. Good morning. I'm Mitch Skelton. I'm the director of the pharmacy, Oak Park Pharmacy here at John Knox Village. A little bit about me. I have been with John Knox now. December will be 10 years. Have been the director of the pharmacy for those 10 years. Have seen a lot of growth. Have seen a lot of new faces come and go here at John Knox Village, and have had a really, for someone who has practiced for 30 years now, it's a good environment to hopefully be your last practice engagement. I mean, I practiced originally. I was a hospital pharmacist and practiced in the hospital exclusively for about 10 years, and then retail, and then finally into long-term care, where I worked for the last about 20 years. I'm from a small town in Mississippi, South Haven, which is just a suburb of Memphis, and grew up there, joined the Army at the age of 19, served for 34 years, which is hard to believe that I did that. But I went in as a private, came out as a colonel, and most of that was the first few years I was a paratrooper because I didn't know any better, and I thought it was something to be, it was something to do, and it is a lot of fun at 19. But at 65, you start paying bills that your body did a long time ago, and so I worked. After I got out of the Army, I obviously went to college and studied engineering originally, and then my cousin, she was and still is a very good friend of mine, and she had an opportunity she wanted to be a pharmacist, so. I wasn't, I was a bachelor, and so she wrote me a letter. I was living in Michigan, working there, and she said, "Look, I'm going to go to pharmacy school, and I don't want to go by myself. So, would you be interested?" And I said, "Well, I'll take the exam. You had to take, well, and you still do. You have to take a board qualification to see where you get placed so you can get in a slot to go to the professional school." And unfortunately, she got mad at me because I got in a year before she did. And so I went back home to Mississippi, went to University of Mississippi to study pharmacy, and I did and finished and started practice there in Mississippi and then in Tennessee. And in 2003, I was asked to open a pharmacy in Orlando, a long-term care pharmacy in Orlando with the company that I was working with at the time, and moved down here. And my wife Angela and I, we've been married now 28 years, and so we moved down here and settled in Orlando, and then started servicing nursing facilities primarily. And one of the nursing facilities I served was ran by a gentleman named Joe Trainer. And so I was preparing to retire and was working with this young lady back here at a little pharmacy over in Mount Dora. She had just finished technician school at the time, and said, "Look, I'm looking for a job." And I said, "Well, I'm looking to retire, so I'll show you what I know, and then I'll get out of the business." Well, Mr. Trainer decides that I'm not going to retire, and calls me up one day and says, "Hey, we have a pharmacy here at John Knox Village, and we need somebody to run it for us. And would you come over and let me talk to you about it?" And I said, "Sure," because I'm that kind of person, and I've known Joe for a long time. And so I showed up, and he said, "Here's the pharmacy. I'm expecting you'll start when?" And I said, "Well, I haven't taken the job." And he goes, "Well, you showed up, so I'm assuming you want the job." And I said, sure. So I've been here ever since. And it's a rewarding experience, and it's something that I feel very strongly about, is taking care of our residents and our employees and their family members. The other thing that I'd like to mention before we get going is I don't really ever get a chance to brag on the other parts of John Knox Village medical infrastructure. One of them that I really want to bring to everybody's attention, if you haven't had a chance to visit Majestic Oaks and tour it lately, Majestic Oaks is undergoing a renovation that is just breathtaking, and it's really going to make the nursing facility there. It's already a 5-star qualified nursing facility, which is the highest level you can achieve. And it's in the state of Florida. It's above the top 10 of nursing facilities in the state, and it's in the top, I think, 100 nationally. So it is really a diamond of an institution. And if you haven't visited, you really should take a second or two, call them, and they'll give you a little walk-around tour, I'm sure, and show you just how wonderful a facility that is and how caring that staff is. The other part is our assisted living, which is Oakview Suites, which is over in the next building over in the center over there. And Oakview Suites is also developing a new format to try and take care of residents. They do a marvelous job. And of course, assisted living is not skilled nursing. It's a little bit different. It's where you just need basic help. You're not really being, you don't need a lot of nursing support. But they do a marvelous job. And then of course, our home health, which takes care of residents and visits residents and helps do rehabilitation there in their home so that you don't have to go into any other level of care. And all of these, I say that to say that the pharmacy supports all those levels. And we also support our independent residents. And this is the way I always used to start this same program for the last 8 years, I guess now, or 10. Who here has ever visited the pharmacy? Who here uses the pharmacy? Well, we appreciate the fact. I used to get 2 or 3 hands that even knew we had a pharmacy on campus. So now it's heartwarming to see that at least more people know we're around, and we obviously are not. We want you to use the pharmacy. It is your pharmacy. You support it, and you paid for it. So it's something that we feel strongly that our residents should be able, and we encourage you to come visit and let us speak to you about becoming patrons or customers and patients of ours. So with that, we'll get started. This is Coffee With. Here's just some general information about the pharmacy. We're open 9 to 5 for retail. We usually are there, believe it or not, somewhere around 6 or 6:15 in the morning, taking care of orders for Majestic Oaks and for Oakview Suites. So we take care of those folks that are in the skilled facility and in the ALF. We take care of their orders that came in overnight, and then we start doing our retail residents and our employees and their family members, their orders. We have a drive-through that's open 9 to 5. Our lobby's open till 4:30, and we're closed on Saturday and Sunday, but that doesn't mean the drive-through. The drive-through is open on Saturday. We have deliveries Monday through Friday. Our delivery is between 9 and 11 in the morning, so if you do not wish to come and pick up your medications, we can actually deliver them to your house. You have to sign for them so that we have a clear understanding of where, that everybody got what they were expecting to receive. We have a delivery on Saturday. That's only one delivery on Saturday, and that's around 4 p.m. We don't deliver on Sunday, but we're on call 24 hours a day, 7 days a week for the skilled facility. And we have been known, if we had a resident needed something, we'll try to take care of that need as well. Let me see if I can get this next one. On-campus delivery, we talked about it. We deliver even to our employees. If they're at their workstation and need something delivered, we'll actually deliver it right to where they're working, so that they don't have to take off from work to come and get their medicine or anything their folks might need. We have a limited footprint, a limited space for over-the-counter items or for any sundry items that someone may need. The good news is we have the ability to get almost anything you would need the next business day. So if it's something that you have used in the past and we can find a source that will supply it to us, then we'll try to make sure we keep it in stock. If not, a lot of the residents prefer to say, hey, I need a bottle of you fill in the blank, and I want it delivered, and we'll say, well, we'll get it to you tomorrow morning at between 9 or 11, or we'll get it to you tomorrow afternoon between 3 and 5, our second delivery. And again, the over-the-counter items, we talked about that. Special orders are available. We've ordered everything from walkers to lift chairs to you name it. We pretty much ordered it. I don't think we've ever ordered a bed, though. I think that's the only thing, a hospital bed I don't think we order. But again, that is something that is available here on campus. The preferred method now, nationally even, is electronic prescriptions. And one of the things we have been able to do at John Knox Village with our electronic infrastructure is we've been able to incorporate almost, well, I'd say 99% of all of the electronic prescriptions that are out there. We are now signed in to be able to manage those. Well, what does that do for a pharmacy? That is a quicker, cleaner, more specific order coming from a provider. So there's no ambiguity when your doctor says, I want you to get your blood pressure medicine, it's right there. And if there's an error, it sticks out like a sore thumb, and we're able to respond to that physician or to that provider and say, hey, did you mean to write this order for this person? And it's much faster than it used to be when we would have to go in and sit with our physicians, and then they would write a script and bring it to the pharmacy, and we would have to interpret what they were trying to order. Exclusively, we take care of, again, residents at any level of care. We take care of employees, and we take care of employees' family members. And that was a decision that the board made that I feel is very wise. It gives us two things. One, the flexibility to attend to our patients' needs the way they should be attended to. We don't have to hurry and push people along like you would see at a major Walgreens or a CVS that just don't have the time to spend with their patients the way we do. And that's part of why I enjoy this practice setting, is because if a person has a question, we can stop what we're doing and address that question right then, or at least get the information that patient needs and start looking up the answer to it and get back to them. And we're pretty good about getting back to them because, again, Callie will not let me forget. She writes it on a big white board, hey, you need to call Miss Jones by 3 o'clock today. We just talked about personalized consultation. Callie is our billing specialist, and during this presentation, I'm going to go over the first parts of Medicare or Medicare, A and B and C and D, and then she's going to finish up with Part D, which is a prescription drug program, and go into detail how we do give a personalized service. And some of the folks, I know some of the folks here have taken advantage of that, and we encourage, or I personally encourage everyone to take the time to look at your medication need. I always say it should be like you balance your checkbook or like you look at your will. It should be something you do on an annual basis, because you don't know how things change. Sometimes they never change. And luckily, I'm one of those people that's been on the same medicine, it seems like, my entire life. But a lot of people, medicines do change, and they change pretty often. So we encourage that, that we've got you on, or we don't really do anything. We just help you make decisions on what is the best Medicare drug program to be involved in. Consultation with a pharmacist, again, like I mentioned a minute ago, we actually can make appointments and sit down and go over everything from all the medication someone may be taking to a specialty need that someone may need, to just want to get an idea of what the services are. And we like to do that because we, as you can guess, we like to chit-chat. And it doesn't cost you anything. Well, obviously being part of John Knox Village costs you something, and this is a service that comes with no additional cost. All right, Medicare prescription drug coverage. Everybody in this room, including myself, not Callie, and I'm sure not Candace, or have some sort of involvement with Medicare. Medicare obviously is a program that started in the early 60s, and it was a way of the federal government decided they were going to get into the insurance business. And this insurance business they got into was trying to use taxpayer money and tax us, the working folks of the United States, and say, for your taxes, we're going to augment and supplement your insurance when you become a certain age. And that age is, for most folks in the beginning, was 65. For me, it was 65, 60, I still got to go on 65, but I can't go on Social Security until I'm almost 70, I think, now. But we're going to go over some Medicare basics. We're going to go over some terminology. We're going to go over a really important is open enrollment. Like any insurance plan now, the Medicare Part D prescription drug coverage program has an open enrollment period. This open enrollment period is very important to anyone who is on medications, and I'll tell you why. If you use Medicare to help pay for your prescription drugs, the open enrollment period is when you can make changes without any penalties, without any questions asked, and that goes back to that annual review of everyone's medication needs. Supplemental plans, we'll talk a little bit about that. Penalties, yes, like people that have paid taxes know if you don't pay them on time, Uncle Sam has his hand out and he wants more money. Well, same thing with Medicare. If you choose not to enroll, there are issues that you have to deal with, and there are some residents that are found themselves not enrolling years ago, and now 20 years later, it's just not it's cost prohibitive for them to enroll, and that's a tough thing to have to handle. And then we'll talk about how primarily Callie, how she helps our residents sit down and go through their medication needs and doesn't ask anyone to sign up on any program. She never will do that. What she's going to do is take information you give her, run it through the federal government website, and say, here are the plans that the federal government thinks are the most advantageous for you to sign up with based on your current need. The 4 parts of Medicare. There's Medicare A, there's Medicare B, C, and D. We'll go into detail on a little bit of detail on each one of them, but A, if you think, this is the way I always tell patients, A is hospital, A is nursing facility, B is in the doctor's office. If you go to a doctor's office or you go to an infusion clinic, this is where B. If you have a wheelchair that is provided by Medicare, B is where that wheelchair is paid for. That's where the funds come from. Part C is a hybrid. They're the Advantage plans, and those are non-typical Medicare. It's a non-typical Medicare plan. By that I mean the federal government contracts with an independent insurance company, and Aetna, Humana, whatever that, and pays them capitation rates. And what capitation rates are pre-approved amounts of money. And if there's an accountant out here that wants to correct me, please do. But basically, they contract and say, we're going to pay you to take care of this patient population, the folks that sign up with you, and you make your money based on how economic your plan is. And then Part D is the prescription drug coverage specifically. And like I mentioned, Part A covers inpatient stays. Inpatient starts when you are admitted to the hospital. Your Medicare Part A will cover just about everything except for your co-pays and your deductibles, for your room and board in the hospital, for your treatments, for your diagnoses, and for care. There's a few things, sundry items and personal care items that it will not cover. And it also, as I mentioned, it covers a qualified stay, which means if you went to the hospital and were admitted and stayed for 72 hours and needed follow-along care, and the hospital is going to discharge you to a skilled nursing facility. And as I mentioned earlier, Majestic Oaks is one of the best. It's absolutely one of the best in Florida, and it's really a unique nursing facility. They have a very high provider to patient ratio there, which means they have a lot of people taking care of you if you have to go, and inpatient rehabilitation. And basically that's what A covers, is you're being rehabilitated. Let me speak to you another personal note. I had retired out of the military and was still, I considered myself to be in pretty good shape. I was, ran quite a bit and was pretty active. Actually took up playing golf and doing deep sea fishing since I lived here in Florida. And I started having a lot of pain in my back and in my left side. So I go to the VA, they look at it and they go, buddy, we're going to have to do a hip replacement. And I said, I don't want that. And they said, well, it's not a won't, it's a have to, if you want to keep walking. So the procedure was done. I had to have my hip replaced. And the rehabilitation piece, I had a good friend of mine that he had to have his hip replaced. And I was very fearful because he had spent almost 6 months in rehabilitation to get back to a normal activities in life. I spent 30 days because of the intense, good rehabilitation treatment that I received in my home. Within 30 days, I was back at work and playing golf. Never played it well, but still enjoying the game. I don't get to run anymore, but I do have an old bicycle that I'll get out and pedal around the block every now and then. But that's part A. Let me go back. All right. We talked about, yep, okay, so part A, for terminally ill folks, and we just lost my father-in-law, and when he was put into hospice or terminal care, Medicare picked up 100% of his requirements, which was obviously a godsend for my mother-in-law, who was spending somewhere in the neighborhood of $6,000 a month for his care. But we lost him. But it was something, again, it's a benefit that all of us as taxpayers who have paid into the Medicare system, you've earned it. Home health services, that's the part that I just spoke about. The home health folks, I had a home health nurse that came twice a week just to check blood pressure and vitals and make sure that I was healing correctly, that my stitches were being taken care of. Then 3 and 4 times a week I had a physical therapist that came, and he was not the most fun guy. The first week I thought he was a bully, and I wanted my wife to shoot him, and she wouldn't do it. And so but by the 4th week he had me out walking 2 miles, and the 3rd week, and then the 4th week I was back at work. So it is a good thing. Eligibility, we talked about it. 65 or older. You have to have paid into the system for at least 10 years, and those 40 quarters. And if you go to, and I'm sure everyone has, or I hope you have, at least taken the time to go to the Social Security website, put in your Social Security number, and look at your account. Because you have one. If you've lived here and worked in the United States, you have and have a Social Security card, then you have an account, and it tells you specifically what your benefits are, how much you would make for Social Security and whatnot. And I was pretty impressed at 65 the first time I went online, or 64 first time I went online and looked at it. I was like, wow, there's a lot of good information here to plan going forward. Obviously, if you're disabled and you have Social Security disability, you're going to use Medicare earlier, and that's again a benefit based on need, and that need is specifically judged by the Social Security. They will initiate a claim, and I have the same good friend that had his hip replaced that took so long to. He's on Social Security now. He was a pipe fitter and worked in a steam plant in outside of Memphis, and he worked there 30 years, and it just wore his body down to the point that his hip was completely gone, but it took him quite a bit longer to get rehabilitated. So he was on Social Security disability, and still is, and has Social Security, and he's a year younger than I am. End-stage renal disease, people that have kidney failure or have a need for dialysis, they can enroll in Medicare obviously earlier. And then ALS, or Lou Gehrig's disease. See, usually when I say Lou Gehrig, there's a lot of folks in most of the talks that I have, they don't know who Lou Gehrig was. And any baseball fan worth their salt knows who Lou Gehrig was, who was part of Murderers Row, and one of the luckiest men alive, if you ever get to watch the movie. The disease that he passed away from was ALS, and it was named after him, actually. Part B, real quick, Part B is durable medical equipment. And these are procedures that are done under the auspices of medical professionals. So I always, like I said, I like to think of Part B as treatment in a physician or provider's office setting. So if you have a need for an infusion drug, let's say you have some sort of cancer that needs to be treated a special way and you have to go in to a clinic for that. It's not covered under A, it's covered under B. Durable medical equipment. If a certificate of need, let's say you have to have a lift chair in your home, and an orthopedic physician has evaluated and written a need for this, then Medicare Part B, you can actually file a claim under B to get that piece of equipment paid for, or at least help to get it paid for and installed and maintained in your home. So that because the need there is specific to getting better and being mobile, if you think of it that way. They want you to, the Medicare system wants you to have the same kind of life that we want you to have here at John Knox Village. Be as mobile, be as active, be as engaged, root for your favorite football team over there, my good Aggie over there, and I'm sure there's some other folks that are college football fanatics. I'm one, obviously, but anybody from the SEC has to be one. Oxygen, obviously, if your own oxygen, your oxygen generators or oxygen tanks are covered under Part B, and it is a very good, very diverse, very wide spread program. There is a catch, however. Only certain licenses are given out for Part B, and those licenses can be looked. You can look them up by your zip code. Some of them are pharmacies, some of them are medical equipment providers, oxygen providers. You go to the Medicare website, you put in your zip code, that's all you have to put in, and it'll tell you these are the providers under Medicare Part B in your zip code area. And those are the ones your provider, the medical provider who's insisting that you get this equipment, they would write that order to that specific entity, and then you would receive your equipment. And home health services. The services cover if you're housebound and need skilled nursing. Again, I'm the great example there. If you're coming post-surgery and you're not going to go into a skilled nursing facility, you're going to stay at home and do your rehab, which I don't like even going to the doctor. and luckily I have one that works directly above me, and she takes care of pretty much all my primary care needs. And if you haven't visited Martha Cullen, she's our nurse practitioner here on campus and does a fabulous job. As a primary care physician, I don't know of any other provider that is more caring and more personable than Martha. And I don't say that because she's my provider. I say it because it's the truth, and I'm not the only one that would agree to that. Ambulance and movement services, a emergency movement to a hospital is covered under Part B. A routine movement that is deemed necessary is covered under Part B. What is that? Again, if you are receiving treatment and you cannot be moved by a secondary means like a personal vehicle, and you must be moved by a professional, role in Part B as well. And then this is something new as well. If you have had a transplant, a kidney transplant, and have not filed for 36 months, then you're eligible for immunotreatment under B. Part C is the Medicare Advantage plan. As I mentioned earlier, these are private providers. These are private insurance companies that have taken on the job of the federal government, the Medicare system. I'm enrolled currently in Part A and B. I don't enroll in Part D because I'm a veteran, and the Veterans Administration and being a retired military person, we fall into a category where we don't have to have prescription drug coverage because of TRICARE or TRICARE for Life in our case, and because of the Veterans Administration. That's where all my medications come from. You would think they would come from down the street. Some of them do. My wife's do. My wife does, but not mine. As you can, I'm not going to go through all of these, but you can see it's pretty much the same list of treatments, the same list of actions that Part A or B would take care of. Part C, or the Advantage plans, have to do that. The difference is that some of the advantages, I guess, if you want to call it an advantage, are you get some perks under Part C that you don't get under A and B. Gym memberships. Again, we have a gym right on campus. I think we have two, actually, that are very, very good places to work out. But for someone who lives in the community setting, the Advantage plan, some of them offer some dental provisions that are like cleanings and screenings. Not a whole lot of surgery, I don't think, but there are some. Fitness programs, gym memberships, some over-the-counter drug items that they will actually cover, and again, acupuncture and chiropractic services. Let's see. Okay. All right. So here's some of the limitations. When you talk about Medicare A and B, any provider that accepts Medicare, if you're covered under A and B, that provider's on your plan. You can go, and if that physician or provider is accepting new patients, then you're already in the program. Part C is not that way. Part C is if you think of a PPO or of an HMO, they contract with their physicians. They contract with their dentist. They contract with their physical therapist. And you, as the patient, if you accept the Advantage plan as your part of Medicare, then you are accepting that network. So you have to, when I say in-network, out-of-network, everybody understands what I mean. And that's what we're talking about. They set up a network that is supportable, and in a lot of ways it's just as good as a Medicare A or B provider, but it is, in a lot of ways, it kind of locks the patient down to going to who that plan, and the plan has the ability to get into the treatment that a provider wants to initiate. What do I mean by that? If your physician said, I want you to get X, and this is a treatment, and I want you to have this medicine. Well, now in a Medicare Advantage plan or a Part C plan, the insurance company approves that. And if they disapprove it, they have to have a vehicle in place so that you can request a review and request some a way of getting that treatment if it's needed. But they have a process where they can deny it, and a lot of them do because of economic reasons, and that's why I wouldn't see myself in an Advantage plan, but a lot of people swear by them, and one of my best friends is in one and loves it, and I don't have an opinion other than I'm new to the Medicare game. This is my first year, and all I knew was, my wife was like, well, you got to register for Medicare. And of course, then she made fun of me the whole rest of the day because she's 11 years younger than I am. So I'm counting the days until I get her back. And then unexpected costs, like we talked about, costs such as, you get a denial of a benefit. Well, now guess who has to pay for that treatment if you want it? So you got to be real careful. Not saying it's a bad thing. Please don't think I am. But I would ask that we do a lot of due diligence before we sign up with those sorts of plans. And the Advantage plan, okay, this is more out-of-pocket costs. Some of the higher cost things are excluded here. You have to go in network, talked about it. Oh, and a standard plan, a standard Medicare Part D plan and an Advantage plan. Can you have both? No, you can't. You can have one or the other. Open enrollment. This is where you can change from any plan over to a new plan if you so choose. And again, there are the eligibility requirements and cost. The premiums, the Part B premiums, you don't really pay for Part A. Let me just make sure that's clear. Part A is a benefit, a total benefit. B is a supplemented insurance plan, and in my case, I pay every 3 months, I think it is, to Part B. Angela writes them a check that says, that I'm covered under Part B. And I think that's the way it works. And then the Advantage plan is the same way. You're going to pay a premium every month to that insurance company to be part of the plan. You're going to have a deductible. Well, you have deductibles in Part B as well, I do believe, right? Part B has deductibles. So there is deductibles. This is insurance, so you do have deductibles. But the deductibles in the Part C plans or the Advantage plans are managed, and they are affixed by that plan itself, not by federal government. Does that make sense? And then co-pays and co-insurance. All right, Part D, that's prescription drug coverage. And to get Part D, you have to have Part A and B. That is the requirement. And at this point, what I'm going to do is pass the old clicker over to Callie, and because she's the Part D specialist, if you will, she will tell you she did it all on her own, but I'm the one that said, hey, you need to learn this. So I feel like I get some credit for saying, I think you're smart enough to learn it. I didn't want to tell her I'm probably not smart enough to learn it, but I want you to become a specialist and take care of residents. And with that, Callie, I want you to take over. Do you need this microphone?
No, I'm going to stand up here.
All right. And we'll answer all the questions. With your permission, we'll answer any question you have at the end. And thank you for your attention to my part of the program.
Hello, can everybody hear me? I'm Callie. I have been with the pharmacy for almost 9 years now. Actually, no, I just started August. The beginning of August was 8 years, so not quite 9. Feels like it, though. Mitch got me right out of technician school. I am a licensed pharmacy technician as well as the biller for the pharmacy. So sometimes when you call, you'll get me on the phone, and I can help you guys fill your prescriptions, too. I started doing this part of the program when Liz left. So this is my 3rd presentation. So if I'm a little nervous, please forgive me. Don't do a lot of public speaking. Going straight into the Part D, it covers your prescription costs. As Mitch said, you have to be enrolled in both A and B. And then you really need to When you first sign up, it's very important that you have either you immediately roll into the Part D, or you have some kind of other creditable drug coverage, like a retirement plan, stuff like that. If you don't, if there's any kind of gap in coverage, whether you have medications at that point or not, you can end up facing a penalty. Is this up or down? Nope, wrong way. You lied to me. Covered under Part D, it provides prescription drug coverage for anyone enrolled in Medicare. These are offered by private insurance companies and cover a wide range of medications, including your generics, your brands, anything for chronic conditions, your maintenance meds for like diabetes, high blood pressure, and most vaccines now are also covered under Part D. Some of the additional benefits to Part D are mail order prescriptions. I have heard mixed reviews about mail order from the residents here at John Knox. Some people swear by it, some people absolutely hate it. And they also offer discounts on some brand name medications. One of the things that Mitch spoke about earlier, when we'll get to it a little bit later, but I have forms up here that you can fill out to just put your medications and stuff on it, and then you can sign up with me either on the portal. There is a link to my calendar, or you can call in and we can schedule a time and a date for you to come in. We'll go through all of your medications, we'll input them into the Medicare website. You tell me which pharmacies you want to use. So if you don't even want to use Oak Park, we'll still offer this service to you because we are here for you guys. So you pick out which pharmacies you want to look at mail order, if you want to look at us, CVS, whichever you prefer, and we show you which plans are going to be the most cost effective for the medications that you are currently on. There are several phases to Medicare Part D. They look a little bit different this year. You have your deductible phase. Not all plans have deductibles, but sometimes most of them have. I'm wanting to say it's right about $500 this year. I'm not 100% sure. But they can be as little as $0 deductible for the plans. While that might sound fantastic, those plans that have those $0 deductibles are going to have a higher monthly premium. So you really want to look at the medications you're on and what those copays are going to be before you decide, oh, I want to have that $0 deductible, because it might not save you as much money as you think it might. In the initial coverage phase, once the deductible is met, you pay $25 coinsurance on your medications and your plan covers the rest. The catastrophic coverage phase this year starts at $2,000. Last year it was $8,000. It's been quite a drop. They have completely eliminated the donut hole, the coverage gap, for 2025. Going over some terminology, some of these are pretty self-explanatory, so we'll go through them pretty quickly. Formulary, that is the list of medications that are covered under any particular drug plan. Not all of them have the same formulary, so which is why it's important to sit down. Even if it's not with me, if you sit down by yourself and want to go through the Medicare website, it's very important that you put all your medications in there to see, because what is covered this year may not be covered next year, and you don't want any of those surprises. Premiums are the monthly payment that you make on your chosen plans. They vary based on the formulary and then whether or not it has a deductible. The deductible is the out-of-pocket amount that you have to pay before your coverage starts kicking in. So obviously if it's a $0 deductible, they immediately start. If it's $100, you pay $100 out of pocket for those medications. There are some medications, some plans, where your generic maintenance medications do not count toward your deductible. So even if you have a high deductible, those ones are going to get those minimum costs regardless, because they bypass the deductible phase. Coinsurance is a percentage of the cost of the prescriptions that you pay. For example, you pay the 25%, and then the plan will cover the additional 75%. So the plan pays more of the prescription costs. Co-payment is basically your part, that 25%. That is your part of the payment that you make. I did add coverage gap in here, also known as the donut hole. For 2025, it has been completely phased out, so there will not be coverage gap this coming year. You'll go straight from your initial phase into catastrophic if you reach that $2,000 threshold. Once you reach that out-of-pocket limit, the catastrophic coverage kicks in, significantly reducing your prescription drug costs. All of your covered medications should be at little to no cost for you. That does not apply to anything that your insurance, that is not on the insurance formulary. So if there's something that you have been paying outside of the insurance for all year, that cost will not change even once you get into catastrophic. Tiered pricing, your drug formularies have tiers, usually 1 through 4. Your tier 1s are going to be your maintenance meds, your generic items. And then tier 2 gets a little bit more expensive, 3 is up there, and your 4s are going to be your specialty medications or things that are just really expensive. Your initial coverage limit, that is the maximum amount that your Part D plan covers before you enter, the coverage gap, but again, that has been eliminated. The Part D penalty is a lifelong penalty added to your premium if you do not enroll in Part D plans when you first are eligible or you do not have creditable, or right after creditable coverage has ended. They have not yet released what the base premium is going to be, so there's not really a way for me to give you an example of what that cost would be at this point, but once we actually sit down, by October 1st, they should have that released. So if you make an appointment with me and you fear you may have to pay a penalty, we can look into what that would be for you. Preferred pharmacies is a pharmacy that is basically contracted with your particular Med D plan. You will get the lowest copays from that particular pharmacy 99% of the time. There have been a handful of times, and those of you that have sat with me before have seen sometimes, even though Oak Park is not a preferred pharmacy, we are in network, it is still sometimes showing cheaper prices because we are a small independent pharmacy and we're not, as big. So I'm not sure why that is, but it's good for us and it's good for you guys that use our pharmacy. Special enrollment periods, that is a time outside of the normal enrollment period where you can sign up for Part D due to certain life events. If you move out of a coverage area, you can change your plan. Or if you are losing your other creditable coverage, you should be able to sign up at that point. Oh, this is a list of some additional the special enrollment periods. So moving, if your plan changes, if you go into an institutional facility, if you join a state pharmaceutical assistance program, financial assistance, if you join enrolling or leaving PACE, or if you are on a special needs plan and your needs change, those are all qualifying events that allow you to change your plan. Open enrollment is from October 15th through December 7th. That is the same every year. This is the main time when you can join in, switch, or drop your Medicare Advantage or Part D plans. It's very important that you look every year, even if you have a plan that you absolutely love. I had a resident the very first year that I did this, decided to come and sit down with me, and they're like, "Hey, I've had the same plan for 10 years. I don't really want to change, but my neighbor said that I should come and talk to you." We sat down, we put all of their information in. They ended up saving $2,000 a year just by changing their medication plan to a plan that they are still on today because it just works so much better for them. It does not hurt to look. Just because you sit down with me does not mean you have to make a decision to change. All I do is give you the information that I pull up, and what you do with that is absolutely your call. You can make the changes or you can stay where you're at. It's whatever you're most comfortable with. If you don't want to sit down with me and you want to try doing it yourself, this is the website that I do all of this information pulling from. It's just medicare.gov. Everything, all of the new plans upload the 1st of October. So come October 1st, if you want to go on and look at everything, you are more than welcome to. I do still take appointments during open enrollment. There's no strict cutoff time. So if at any point you decide you want to have a sit down with me, just give me a call, or I have a calendar now on the portal. If you find the news article that talks about the Coffee With Today, one of the forms is attached. You can download it directly to your computer, and you can actually go in and you'll see all of my available times. You can click that, input your information, and it sends it directly to my calendar, and I mark that time off as yours. Everybody is allotted an hour, so we've got plenty of time to go over everything. I do, like husbands and wives, I do like to have in the same appointment, unless you specifically don't want to share appointment times. So if one of you signs up, the other one does not have to. You can just come to that same appointment time. That's usually why I give an hour. Going back onto the penalties. The penalties are, as I said, for the rest of the time that you have Medicare. If you have never enrolled in a plan or had a lapse in coverage, you will face a penalty. It is calculated based on the number of months that you have gone without credible prescription coverage. Even if you stop taking medications, it's very important that you stay with a plan. I had a resident 2 years ago, I believe, come to me. Well, I'm not on anything expensive. I'm going to drop my coverage. And I'm like, do not do that, because what happens? Heaven forbid. What happens if you end up on a medication that's really expensive? Well, then you don't have coverage, and you're stuck paying that out of pocket. You never know what's going to happen. Hopefully nothing, but you never know what's going to happen. I'll absolutely advise everybody stays at least on a minimum plan if you don't have any prescription coverages, or you don't have any prescriptions. Comparing plans, it is important to assess new plans every year just to make sure you know your options. Take a minute, gather up your information. You want to know what your medications are, what your day supplies. Some people like 30-day supplies, some people like 90-day supplies. And I would keep track of what your normal copays are. That way when you look at the plans, you know, oh, okay, well, this is cheaper than what I normally pay, or, oh, no, that's more expensive. You want to know what type of pharmacy you want to use. Do you want to use a mail-order pharmacy, or do you want to use a pharmacy that you can walk into? There are some questions to keep in mind, and I can have these printed and sent out to anybody if you guys want them. I believe this will also be on the portal. But you want to know if your medications are on the formulary for the plan that you are currently on or the plan that you are looking at going on to. You want to know if there are any coverage restrictions, such as prior authorizations or step therapy. You want to make sure that you look into, if it doesn't cover a medication, is there one that is comparable that I can take and have the doctor switch me to? You want to know what your copays are going to be, what your monthly premiums and annual deductibles are going to be. There's a whole bunch of list of things that you want to know, all of which, when I give you guys the packet at the end of your appointments with me, will have all of this information in it. You want to make sure that any plan that you choose, you can use the pharmacy that you want to use. I would not like to have to be forced to use a particular pharmacy, especially if I'd never been there before, if I was happy with where I was at. Remember, if you're on a Medicare Advantage plan, as Mitch said earlier, your medications may be restricted. You may have to use a particular pharmacy, or they will not cover your medication. Supplemental plans. I get questions about supplemental plans all the time. A Medicare supplemental policy, also known as Medigap, can cover many of the expenses for Part A and Part B, like the deductibles, help cover doctor's office copayments, outpatient procedures. Supplemental plans do not cover medications. That is a very common misconception that we have people calling and they're like, well, I have this. It's like, yes, but that is not for your medications. How can Oak Park help? well, each year during open enrollment, we assist with you guys navigating the Part D website. They update that website very often, and it can be quite confusing and cumbersome to try and navigate. So starting the 1st of October, when they update the plans, I set aside time to make sure I know where all of the stuff is. That way, if you guys call and you have questions, I can try and help you guys navigate it on your own, or when you guys come in, I can show you what your questions are, get your questions answered. I usually start taking appointments the first week of October. I have already started accepting appointments because they put my calendar on the portal and I was not aware. But you can do it that way, or you can just call the pharmacy and ask to speak to me, and I can set up the appointment, whichever is most convenient for you. I am here Monday through Friday, usually till about 3 o'clock, so you can call at any point. My appointment dates are Tuesdays, Wednesdays, Thursdays, and I typically block out an hour for everybody. That way you've got plenty of time for questions, if we need to redo anything, that kind of stuff. It is very important that before your scheduled appointment, at least a day before, you get that form back to me, whether you email it to me, which you can do because I have my email on my business cards down there, or you can just drop it by the pharmacy and anybody can make sure that it gets into my door. That is so that I can be pre-set up when you guys walk in for your appointment and have everything ready so we can go ahead and get started. Otherwise, you have to sit there and I have to enter in everything one by one, and it just wastes your appointment time, and I'd really rather not do that. The meetings for these are held, there is a door right next to the pharmacy window that anybody can direct you to it. You walk straight into the pharmacy lobby and you just keep going straight, and that is the office where I sit. Does anybody have any questions? Yes, ma'am. Oh, I'll give you a microphone too.
Where's the pharmacy located? I'm a newbie.
Okay.
Well,
Did you take it off? It's down on the floor.
If you went, do you know where the back, where Oak Park Senior Services building is? Okay, then.
If you go down Majestic Oaks Court, which is a dead-end street, Majestic Oaks Court, is that correct?
Right.
Yes.
Okay, then there's a road that leads to Oak Park Senior Services Center. If you go down Majestic Oaks Court, and then on the right-hand side, there's a road that leads you to Oak Park Senior Services Center.
We lovingly call it the back gate. So if you went right out here and went down to like you're going to Majestic Oaks, right before you get there, you're going to take a left, and you just follow that left, and it's going to just wind around by a little pond, and once you get to the end of that road, there's a lift gate, and you drive up and it opens, and that's Oak Park Senior Services. Now, not only is the pharmacy located there currently, the outpatient physical therapy office is there. The clinic, the primary care clinic, is upstairs. So it is a very useful, very easy to get to from here. And I would highly encourage you to come visit. We're really proud of the facility, and we would love to show you around and get some information. Obviously, it's not our job to try and, well, it is our job to try and encourage you to use the facilities that are available, because they're yours. When you become part of the family here at John Knox Village, those services, you pay for them, and you deserve to use them. Other questions?
Yes, who's gonna win the national football championship? No, Mitch, I appreciate you folks doing this because we use a lot of medication. I have a couple questions. Is this gonna be put on YouTube here or not? Okay,
Yes, sir.
And the second question is, do you folks, come under the influence of the pharmacy benefit managers in pricing your drugs?
We do not. We are we're an independent pharmacy. Now, we do contract with a purchasing group. So if when I say a co-op, if you're from the country, then co-ops are where all the farmers go, and they enter in an agreement, and the co-op actually does the pricing for supplying seed or parts to a tractor or whatnot. In the case of independent pharmacies, there are purchasing programs that several independent pharmacies sign up, and those purchasing programs actually negotiate what our wholesale prices are for medications or sundries or anything, everything from rubber gloves all the way, I guess, to a jet engine if you wanted to buy it. And they're all, we pay a little bit of money to be part of the program, but they negotiate with the major wholesalers on what our prices are and what our rebates may be and what our time to be able to order, how much we can order of a certain, if it's a supply of a medication that is in short supply, or if it's not manufactured, and you'll find out, and in doing this for as many years as I have, we try to forecast certain types of medications that are manufactured certain times during the year, and then they come into short supply toward the end of a particular time. And so we try to make sure that in the case of Majestic Oaks, as an example, the patients there, if they're on a specific need for like pain management, we make sure that we have a stock or a pathway to get those supplies on a regular basis so that we're not in short supply. So did that answer the question? Thank you. Other questions? Oh, there's got to be another question. One more question. Well, again, let me ask y'all a couple questions. Was it beneficial? Did we learn anything today that we didn't know? Well, then it was time well spent. Did we stir up enough interest for someone to look at their medications and say, hey, I need to see what I'm paying for these and if I can save a little bit of money? Well, then it was worth all the time that I made Callie do this, put the presentation together. So, with that,
He's got one more.
I'm sorry, Mr. Well.
On the people that participate in hospital activities like the surgeons and the anesthesiologists, I've run into situations where once or twice the anesthesiologists were not under the network, so they charge us separately. Is there anything that, other than you go to your surgeon and you say, you're an anesthesiologist, come under, I have Florida Blue Cross Blue Shield, but is there anything that can be done about it if they don't come under that? Or?
That would be
If I understand the question, again, a specialty type of practitioner, and anesthesia it's a specialty. The hospital that is providing that service, they should accept and they should explain what they accept as far as insurance and for staff members, people that have privilege to practice in that institution. and your insurance company that you pay your premiums to, and again, this has nothing to do with medications, it has to do with general medicine, is they have a requirement to inform the consumer or the patient, which doctors and which groups of physicians and which specialties that you have to, try and get, that are part of their network, part of their program. And it's important because there are times you would, like if you went to hospital A and they don't accept, they don't accept Blue Cross Blue Shield of Florida, or part of their staff won't accept that for payment. Well, the hospital might, so the hospital stay may be, and again, it may be covered under Medicare, but your insurance may not cover the group that did a procedure for you. And the person to talk to there is the insurance company themselves, and go, what hospital do I need to go to make sure that most of this treatment or most of this procedure is covered? Does that make sense? Yes, ma'am.
I just want to give a testimonial because I've been using Oak Park for a long time. It's so convenient, and I had a period of time where I was changing medication about every couple of weeks, and they'd call and check to make sure that I wasn't taking both of them at the same time. You call up, and they'll deliver it that day or the next day, or if there's something you need, and you just don't feel well enough to go out. I mean, I'd be happy to answer any specific questions, but they've been great. And Callie saved me a lot of money last year on Part D.
Thank you very much.